Thank you, Chairperson, and thank you, Dr. Mohanty, for giving me this opportunity. You have already summarized the entire session, and I think you have done it in a very succinct way. So I think it's much easier task for all of us. So as he rightly said, there are few important considerations when we look at these supracondylar fractures. One is the distance of fracture line from the implant, which type of implant is there, whether CR or PS, whether the component is stable or not, how is the bone stock, how is the combination, and what is the fracture pattern. So before you make any judgment about what to do, you need to know this basic 6 information, and based on that you will take your decisions. We've got a lot of implant options, and we'll see through this whole thing. We've got buttress plate, peri-articular plate, locking plate, retrograde locking nail, antegrade locking nail, revision with stem, revision with augments, and of course distal femoral replacement. Now if you have to have the algorithm, you must first decide whether it's a stable or unstable component, whether it's more than 20 millimeter away from the joint line and non-comminuted, or less than 20 millimeter from the joint line or comminuted. If it is more than 20 millimeter non-comminuted, you prefer nail. If you have less than 20 millimeter from the joint line and comminution present, you should consider locking plate. And of course, if you have an unstable component, you have got these choices which the other speakers will talk about. Now before I proceed further, we all must go to our basics, and we know that for any healing to happen, because we are talking about fractures, we need to have good cells, good growth factors, and good scaffold or good bone to allow the enabling. As is our biology, so is our orthopedics, with little help from biomechanics, and that's the help I'm going to talk about. Again, some basic things, and I think we should not move away from our root thing. One must know about the fracture healing well. One must know about how the periosteal diameters make a difference and how the fracture strength changes from day to day. Now single plate versus dual plate, and I may be accused of being dogmatic or being very radical, but I think there is no role of, after having done many periprosthetic fractures, I have realized there is no role of a single plate in any of these supracondylar periprosthetic fractures. And I say this because it's not the same elsewhere. Because you have used the cement, the biology is poor, the amount of forces there are tremendous, and even a very well done plate here will fail, because most of the time the fracture healing occurs either because of the good biology and good compression. If you put a locking plate only on one side, the failure rate is unacceptable. I will not say that no, there will be many people who have done single plate and have succeeded, but the amount of failure that you get in single plate, I don't think that is worth the effort. So either you nail it or you plate it, and if you plate it, either dual plate or a nail and plate combination is best to reduce the unsuccess rate to an acceptable standard. Keywords: reduction of metaphyseal shear by medial plate and decreasing stress per unit area by using large working lathe. So how to execute it? Neutralize the forces on the medial side, and you use a long plate on the lateral side. Why people are afraid of doing medial plate is because they feel that it's unsafe. A lot of studies to show that now you can put the medial plate up to 8 centimeter distal to the lesser trochanter. Our own studies, which was done for a different thing, has done the anatomical study and shows the femoral neurovascular bundle is quite away from the area that you need to plate. So if anyone is interested, they can read the entire anatomical standards. Now the one and the biomechanical part of it is that it has been clearly shown that it is much superior biomechanically to do a dual plate. And why not do it then? The key point, as I said, how to execute is get a good reduction. On the lateral side, there should be polyaxial screw placement opportunity, long enough plate that, and use any measure that enhances pull-out strength and enhances the biology, and leave the metaphyseal and comminuted area alone. If you did all that on the lateral side, you'll be good. And on the medial side, as I said, you have to use the plate in the buttress mode. Just one small, we have a clinical case discussion here, but we'll just run through this case. This is again a standard TKA. We did it robotically, and one of the reasons for increased periprosthetic fractures, in which we may see an epidemic, is the use of robotic technology. My own case where we did this, you'll see the pin placement track there, and 4 weeks post-op, this is the X-ray, we had a periprosthetic fracture subsequent to the pin placement. And that is the standard thing that we did. This is the right and the left side. We put a plate on the medial side, simple semitubular plate, but the ideal plate is either a Philos or something that is used in buttress mode. But even a simple plate that neutralizes the shear like a semi-tubular plate, is easy to execute, is good enough for this. So that's the lateral. And don't worry about plate being little off on the lateral side. And this I learned for Dr. Tanna. He said, don't worry about that as long as you get a screw purchase and you span a long enough length. Another case, and this is the case I would want to put would want to show and buttress my case for using a dual plate. This is something that we did, and I hope and I believe that we did a good job. 1 year it stayed, then started failing, and then no, I think this is different X-ray. Sorry. So then we moved on, and it failed after 1 year, and we had to ultimately do a nailing and a plating again. At that time, we felt that we have again lost the plot, but we had used BMP fortunately. So the biology was there, and hence we could get union over time. So you can say exorbitant coalesce after 2 years of this. The biomechanical principles, you may feel that it is not very sound here. We also felt that it was probably day one failure, but I think BMP did the trick. The fact that we used two systems, a plate and a nail, helped. Again, a similar, this is not my case, but I helped later in the second part of the case. This was done, and then we had a refracture of periprosthetic. So you can have a re-fractures also that bothers you. Of course, when you have that, you have to think about allografts, massive allograft, and spanning it much beyond. And then this is the final union for this case. And sometimes life gives you googly, like this case. We'll have case discussion. Again, something that you don't have enough space to do we use the case. So the principle is that you use dual things. This case I did with Dr. Tanna, someone who said Gustafi mask with an arthroplasty surgeon. So we said we'll take the person who will be able to do the Gustaki mask, and that's the result. So the only place where you can actually do a single plate is this one, and that is why I have kept it at the end. Very simple, straightforward fractures where you can do this. So this is the only indication for me to use a single plate. All other things, I feel that we should use dual plate or dual fixation method. The take-home message is that we should recognize fracture, reduce it, splint, get CT scan to visualize if there is an articular extension, assess radiologically and interrupt the bone quality and the prosthesis stability, plan fixation depending on the type of fracture based on classification, whether it is with or without intra-articular extension, bone graft where necessary. And I think most cases, if there is combination, you must bone graft, either the allograft or the autograft, where if the patient is affording, use BMP, because you are giving one shot and you are trying to minimize the failures. Protect fractures and gradual guarded mobilization. Of course, rehabilitation is important. As I said, these are the three critical elements: good bone stock, BMP if possible, and good biomechanics. As a surgeon, we have to be an orchestra playing thing with lot of things to juggle, and I think biomechanics, biology, and the bone quality, and most importantly, decision making is the key. I thank you for your attention.